Hello again, all, and welcome to the Science of Childhood Cancer lecture series hosted by the St. Jude Comprehensive Cancer Center. I'm Dr. Melissa Hudson, co-program leader of the Cancer Control and Survivorship Program. On behalf of myself, my co-program leader, Dr. Greg Armstrong, and the Science of Childhood Cancer team, we welcome you today. We are launching the fourth season of this lecture series, and it's been incredible to see such enthusiastic engagement from the global scientific research community over the last 3 seasons. In fact, since the series began, we have had more than 4,200 individuals join lectures from all over the world. So we welcome you, new and returning attendees, and we are looking forward to another great season. It's my pleasure today to welcome our speaker, Dr. Kevin Eppinger from Duke University. Before I formally introduce Dr. Eppinger, I'd like to briefly mention that you can submit questions at any time during the talk using the chat function and sending questions to all panelists. Dr. Eppinger has kindly offered to stay on for some time after the official close of the event at the top of the hour if anyone would like to stay for further discussion. And now I'm pleased to introduce Dr. Eppinger. Dr. Eppinger received his medical training at the University of Texas Health Science Center at San Antonio, followed by a family practice residency and faculty development fellowship in family medicine at Baylor College of Medicine. Dr. Eppinger is a professor of medicine with tenure in the Department of Medicine at Duke Cancer Institute and the director of the Duke Cancer Institute Supportive Care and Survivorship Center. Importantly, he's the founding director of the Duke Cancer Institute Center for Oncoprimary Care. And the mission of this innovative Center for Oncoprimary Care aims to deliver evidence-based, patient-centered healthcare across the cancer continuum by enhancing the interface between cancer specialists and primary care clinicians. The center also aims to conduct innovative research with cutting-edge technology that can be translated into the community setting and train and educate clinicians and researchers to extend this mission. Dr. Eppinger is globally known for his research in long-term outcomes following cancer, including characterizing cancer-related morbidity and health status of cancer survivors and conceptualizing risk-based survivor-focused care. His research in survivorship has featured investigations on cancer etiology, mechanisms of and risk factors for treatment-related toxicity, risk modeling, screening and surveillance, and risk-reducing interventions. Dr. Eppinger has had long-standing NIH support for his work. Over the years, he has served on many national and international research forums and editorial boards. Currently, he serves as chair of the American Cancer Society Cancer Screening Guidelines Panel and a member of the NCI Cancer Prevention Steering Committee and the National Comprehensive Cancer Network Adolescent and Young Adult Oncology Panel. He's been a long-standing member of the Executive Committee of the Childhood Cancer Survivor Study and chair of the Chronic Disease Working Group. With that introduction, it's very appropriate for Dr. Eppinger to present to us today, Secondary Breast Cancer, a Paradigm for Survivorship Research.
So much, Melissa, and it's wonderful to be with you. I wish I was with everybody in person. So what I will talk about today is about 25 years of my career in research and in clinical care. And I'm going to focus not just on secondary breast cancer in general, but on radiation-induced. There's many people that have been involved in this research, and I've listed a reasonable number of them. I know that I've missed some of them. Most notably, Chaim Moskowitz, Jennifer Ford, Tara Henderson, Greg Armstrong, Laura Van Leeuwen, Renee, Melissa Hudson, and most notably Les Robeson. Les was my entry point into CCSS and a key supporter for all that we have done over the years. And most importantly, our patients. Our questions should come from our patients, and our answers should be able to impact their care. If I think about second cancers or subsequent cancers in general, currently that's about 1 out of every 5 new cases that are presented in the US. And the etiologies are largely based upon aging, women with breast cancer having then colorectal cancer, things of that nature. Genetic factors, lifestyles or unhealthy habits such as smoking, and therapy-induced, which we'll focus on today, and then some combination of all of those, the interaction between these different factors. So let me take you back to when I was early on in my career. This is a case vignette. Sarah's a 30-year-old female seen by her family physician, me, when I had hair. in Waco, Texas for a routine physical. She has a history of Hodgkin lymphoma at the age of 15 and was treated with radiation to the chest area. She did not receive any chemotherapy. She does not remember anything more about her treatment and has not seen an oncologist in many years. She is otherwise healthy, asymptomatic, and has 2 healthy children. Her young family doc, ponders what her risk may be related to her previous Hodgkin lymphoma and her cancer therapy, and how that may contribute to her long-term health. Of note, this was back in 1999 when I saw Sarah, and if you scoured the literature at that time, there's really very little in this area. It was a year after this that the Sloan Kettering Group released the first report of the Association of Breast Cancer following radiation for Hodgkin's, and then Steve Hancock and the Stanford group followed with a publication the following year, and a really nice seminal editorial by John Boyce, wondering if second cancers are going to be the price of success for curing Hodgkin's disease. And then another seminal paper by Smita Bhatia a few years after that from the Late Effects Study Group, which is the predecessor of what became largely the Childhood Cancer Survivor Study. And Smita noted that the increase in breast cancer in this population was dramatic and higher than what we see in the general population. A few years after this, Greg Adoras at the NCI with a large population-based cohort of the patients in the US, Canada, and Europe identified that it's really our women that are at younger age, those prior to the age of 30, that were at risk. In this talk, I'll talk about several radiation fields. This is an old figure that Haya Moskowitz and I developed for grant submission that illustrates the different radiation fields that we see in childhood cancer survivors: mantle, mediastinal or an involved field, whole lung, and total body radiation. And you see the doses of radiation here going from higher to lower, and then the volume of the radiation fields going from higher on the right-hand side to lower on the left-hand side. And that's important as we walk through some of the things that we have discovered. I'll also mention the Childhood Cancer Survivor Study. This talk being given through St. Jude. I'm hopeful that most of you are quite familiar with CCSS, currently led by Greg Armstrong and following over 24,000 patients in the US and Canada. This picture depicts those that are in the US. Several years back, we looked at the original cohort within CCSS, those patients that were diagnosed 1970 to 1986. This slide only shows those patients that were diagnosed with Hodgkin's, as I focus in on some of their key issues. And what we reported is that over time, the vast majority of these patients will develop a chronic health condition. And if you look at severe or life-threatening or even fatal conditions, by about 27 to 28 years, 1 out of 2 of these patients had a significant problem, or again, had died of a significant problem. And importantly, we see that this trend increases rapidly over time with a cumulative increase of 1% per year within the Hodgkin lymphoma population. Now, like Sarah's question about her risks, as I focus in on breast cancer, this is a paper that Haya and I and our group published in JCO a few years back, where we had the ability to look at our CCSS population and then compare them to a population-based cohort of women who had either a BRCA1 or BRCA2 mutation. And then we compared them to what the SEER standards or what the general population of the US would be expected to have at that time. And what you can see is that our childhood cancer survivors who were treated with radiation had essentially the same risk by age 50 as our BRCA1 carriers, and much higher than our women in the general population. I might emphasize that by age 50, 1 out of 3 of these women have been diagnosed with breast cancer, which is a sobering statistic. We further broke that down looking at different fields, and you can see here our Hodgkin's population, other childhood cancer survivors treated with radiation, our BRCA1 and our BRCA, kind of benchmarking these areas, and then again the general population. Peter Inskip, Joe Neglia, and other investigators from the CCSS showed us that the higher the dose, the higher the risk in a a seminal case control study. And our Dutch colleagues showed us that if we reduce the radiation field from the wider mantle to a mediastinal, we reduce the risk by about 2.5-fold. So high in our group, we looked at that by field within that paper that I mentioned a moment ago, and you see our patients that were treated with the mantle field and the mediastinal field, again replicating what our Dutch colleagues had shown. Also showing that our whole lung, which is about half to a third of the dose that we see with our other fields, had a significant elevated risk, and that's because of the volume of the breast tissue that is included. We also know from Peter Inskip and Joe Niglia's paper that I mentioned a moment ago that if you also concurrently involve the ovaries in the radiation field, you decrease the risk. So our chest radiation increases the risk, and then as you reduce the estrogen exposure, it decreases as somewhat, never back to population level. So if you characterize what we knew back in the 2008, 2010 time period, what we saw is that there was an increased risk at a young age. And what I want to emphasize is that none of our studies have shown that that risk has plateaued. This is a lifetime risk that appears to have an excess risk throughout the course of a woman's life. Just like women in the general population, it's more common in the outer quadrant, but we also see inner quadrant or other quadrant disease. Not surprisingly, because of the breadth of the radiation exposure, we frequently see bilateral disease that is both synchronous at the time of the first cancer or asynchronous in women that do not undergo a bilateral mastectomy, where they have a second or a third cancer later on. As I'll show in the next few slides, our survival among these women is strongly associated with the stage of disease, such that diagnosing them early should convey a better outcome. And there's limitations in therapy. I encourage any of our women that are diagnosed with breast cancer not to have additional radiation to the area. I've seen some real clinical tragedies in this area, and most radiation oncologists steer clear of this. And if they have had anthracyclines, which is commonly used for many of our pediatric cancers, they really shouldn't have more anthracyclines for their breast cancer, which is the backbone of our primary breast cancer therapies. And then, as I'll show in some of the slides, there's always that competing risk of morbidity and mortality from other health problems, the risk of pulmonary disease or cardiovascular disease or other subsequent cancers. Take Lisa, for example. Lisa was diagnosed with Hodgkin lymphoma when she was 17. She was treated with an old regimen of MOP and then mantle radiation of 36 gray. She had progressive disease and received more chemotherapy, including 200 milligrams per meter square of doxorubicin. Lisa was diagnosed with breast cancer at the age of 33, a very small cancer, 4.5 millimeters on pathology, T1, N0, M0. She had a modified radical mastectomy. Unfortunately, her oncologist did not know her records of her previous therapy, did not know the contraindications of having more doxorubicin, so she was given the backbone of chemotherapy for a breast cancer at that time and developed overt heart failure within a year with an ejection fraction down to 20 to 25%, requiring 3 drugs to get her ejection fraction up to 40%. And unfortunately, Lisa passed away about 8 to 10 years after this, awaiting a heart transplant. And her story is really shown in this paper that Hai and I published looking at mortality following breast cancer. And what you see is 15 years after the breast cancer diagnosis. So if you're diagnosed with your breast cancer age 35, by the age of 50, half of these women are dead. And as I'll show in the next slides, some of the times that's the breast cancer, but it's also those competing risks: heart disease, second cancers, pulmonary disease, etc. We tried to disentangle this, where we looked at the women in the CCSS that had breast cancer, and we compared them to women in SEER, and we matched them based upon their age of diagnosis, their year of diagnosis, and then the race of ethnicity. And so what we saw is that if you look at the expected survival, blue is those women in the SEER, and red is our women in the CCSS. So you see a substantially different survival over time. And this is at 100%. So you're talking about a substantial loss of life. If we looked by invasive diseases, stages 1 to 3, again, we see a very significant difference. And even for DCIS, women that have stage 0 disease, here's what we expect to see in the general population. Instead, this is what we see. Now, it's not the ductal carcinoma in situ that's killing them. It's, again, second breast cancers, third breast cancers, if they don't elect to have a bilateral mastectomy, or those other competing factors, cardiovascular disease, and having other subsequent cancers. So when we looked at them comparing to the women in the general population, we looked at their breast cancer risk depicted in red here. You see that it's fairly similar. But when we look at other causes of death, it's substantially different. When a general population are generally not dying of other causes, it's their breast cancer they're dying from. In fact, when we compared these statistically, we saw that there was a modest but non-statistical increased risk of a breast cancer-specific death of our childhood cancer survivors compared to the women of the general population. But when we compared the risk of other causes of mortality, you see a 5-fold increased risk. During this time, Tara Henderson and our group led a systematic review of the literature. We looked at the incidence and excess risk of breast cancer, the clinical characteristics and outcomes following that breast cancer, and then the harms and benefits associated with breast cancer surveillance, and published that in Annals. And that led to the Children's Oncology Group changing their guidelines, and indeed the American Cancer Society likewise, to starting an annual mammogram or breast MRI at the age of 25 or 8 years after the radiation, whichever occurs last. And this is the updated, at that time, late effects survivorship guideline that Melissa Hudson and Wendy Landier have led over the years. And subsequent to that, we worked with our colleagues across the globe, especially our colleagues in Europe and in Asia and Canada, to see if we could merge our different guidelines together and come up with a harmonized set of guidelines. And an effort that Renee Mulder led with our group, we published in Lancet Oncology in 2013 and then updated in 2020 in JCO, our recommendations based upon this review. And what we said at that time is breast cancer surveillance is recommended for female childhood, adolescent, or young adult cancer survivors treated with 10 or more gray of test radiation. And for those women with lower doses, it may be reasonable. And what we found over time is that group in the orange is actually quite small. We don't use therapeutic doses below 10 gray for many of our cancers, both in the past or in the future. So in the updated long-term follow-up guidelines that was released back in 2018, you'll see that dose threshold was taken out. And if the patient had radiation to the chest area, to the axilla where the tail of the breast tissue occurs, or total body irradiation, screening is recommended. So we looked through the CCSS to see, with these guidelines, are women getting screened? This is a paper published a number of years ago. And what we found is that women that we would like to see up at 100% already by this age had a slow increase over time that picked up a little bit around the time when most women in the US and Canada start their screening. And when we looked at breast MRIs, less than 3% at this time had ever had a breast MRI. So that led to our first randomized clinical trial in this area, Empower 1. And we randomized women into two populations. One is an attention control, and the other is, can we get this information to the woman, provided in written materials and then followed up by a telephone-based counseling session that looked at kind of their pros and cons and potential barriers, and could we increase the likelihood of screening? We were really focused in on mammograms as our primary outcome, but of course also breast MRI cost and other things such as that. And this is a couple of the things that we sent in the mail, just screening with your provider. It provided a little information on the back about the risks and benefits. We provided them a lot of information, but that basic summary of just talk with your provider. You are at increased risk. and the Children's Oncology Group recommends that you get screened with a mammogram and a breast MRI. Women in this study lived in these different areas, again, widespread across the US and Canada. And with that simple intervention, we were able to double the rate of mammography. But notice, while we doubled it, we still only got up to 40% of them getting screened. If I see a woman at Duke or in my previous practice at Sloan Kettering, the likelihood of a woman getting screening is around 99%. When she came in with insurance and I could talk with her about the risk and benefits, the likelihood of screening was exceedingly high. And that's seen by this, that similar statistic is seen by my colleagues in other clinical practices. Yet when we look at women across the US and Canada that we can only send information to them through the mail or by telephone, et cetera, we're only able to get up to 40%. And you'll notice we didn't budge breast MRI, stayed low regardless of the group that they were in. The intervention was more successful for younger women, and that's not surprising. These women were not aware of their risk, and you see that they had a little bit higher likelihood of getting screened. Our women that were 40 to 50 were already in that time period where they might be getting screening in the general population, and we saw that there were other barriers that they encountered. In fact, when we looked at those key barriers, they followed, regardless of whether it's a barrier to a mammogram or to an MRI. I haven't had any problems. The doctor didn't order it. It's too expensive, or I'm putting it off because I have other health problems, or I have competing demands with my family. 87% of the women in our intervention group who did not have a breast MRI also reported their primary physician did not recommend the test. After that study was completed, we did a pilot working with Right Action for Women at the Christina Applegate Foundation, which at that time was funding MRIs, breast MRIs for women at elevated risk through a group called Diagnostic Works. And so all we needed to have was the woman's last year's tax return or their Medicare, Medicaid letter, and we could get a free or low-cost breast MRI. And we used that as our intervention that I'll talk about in the next phase. In conclusion, what we realized from Empower One is that our intervention with mailed print materials and a brief motivational telephone interview doubled the rate of mammograms, but again, nowhere near as high as what we would like to see. During that study, we actually saw women diagnosed with breast cancer and die of breast cancer. We had a minimal impact on breast MRI rate. We realized that intervention might be a little bit more efficacious among our younger women, and then we identified key barriers to address with our next study. And that was Empower 2. And we were funded for that with a start date back in 2018. And now what we did is we took our materials from Empower 1 and put that into our control population. And then we tried to activate our women with a app-based approach to sending them text messages, short video vignettes, things of that nature. And then we also tried to activate our primary care providers, which we didn't do in Empower 1. Can we actually send them information that's specific to that patient and increase their rates? Our primary care provider advisory board for that study that included PCPs of some of the women that were in Empower 1 told us a few things. One is, if you want me to do something, tell me to do it in the first 7 seconds. And this was repeated in the literature time and time again. Our primary care providers are very busy practices. And what they say, don't send me a 17-page instruction sheet. Tell me what you want me to do in the first 7 seconds. Send it by fax or by mail, but really fax is better, proximate to the visit of the patient. And if you send it to the clinical manager, she or he will make sure I pay attention to it more than it's sitting on my desk. So this shows you some of our text messages from Empower 2, all app-based, including video vignettes that are about 2 minutes long, talking about some of the key barriers: cost, why get one, what to do if I don't have problems, how to talk to your PCP. So where are we? Well, we completed enrollment. Our target was 320. We had completed enrollment of 304. We had a very low active refusal rate. Our response rate to our PCPs for our surveys is about 1 and 2. That's not bad. That's pretty much in keeping with the literature. And then COVID, of course, has happened during the study. And so we worked with the NCI and we decided women were not able to get the breast cancer screening because of COVID. So we took the time period to achieve their imaging study and expanded that out from 12 to 18 months. We included end of study qualitative interviews that Jennifer Ford is leading to understand some of the barriers, especially cost related and COVID related. And then in response to a real interest area that Haya Moskowitz and Elena Elkin have, we've been collecting explanation of benefit forms for these patients that get their imaging studies to look at what their cost is. So I've talked about 2 intervention trials trying to increase these rates. The question also arises is, can we counsel women better? Can we talk a little bit about risk? And we've realized over time that most women have a very difficult time having an understanding of their numerical risk. If you ask a woman what her numerical risk is, she tends towards the extremes. Men do the same thing with prostate cancer, going to 100% or 0%. But in fact, it's somewhere in between. People tend to do a little bit better in understanding that my risk is a little bit higher or a little bit lower than what women that are in my peer group might have. So this picture is the breast cancer risk assessment at NCI led by Mitch Gale that works for women in the general population, several risk factors that we've come to recognize increase with women's risk. And so a woman can look at her own risk there, or a clinician can use this in counseling. So Haya Moskowitz and our group submitted and were successful in getting funding to develop a risk prediction model for women that had childhood cancer and were treated with chest radiation. And we looked at a variety of treatment-related factors, the traditional Gale factors, and then other potential modifying factors. We looked in our original cohort for this model, and then we looked to validate it in the Dutch later cohort led by this effort led by Flora Van Leeuwen and Cecile Ronkers, and then also in the expansion of the CCSS cohort. And after a lot of work on Haya and my and many others' behalf, we have the breast cancer probability calculator now successfully loaded on the CCSS site, as you can see here. So if you go to ccss.stjude.org /BCC calc, you'll find that, or our publication that describes the development of that. And through this risk calculator, we can look at a 5 and a 10-year absolute risk. So clinicians can use that. I particularly like this figure that Haya developed that shows that a lot of our risk factors basically stack one up on another, depending upon what their field is, their menopausal status, a variety of other things. And I'll show you a little bit both by examples in those factors in a moment. So if I go to that website and I look at their 10-year absolute risk, let me show you 2 women as an example. I have a 35-year-old that I'm seeing in clinic. She was treated with whole lung radiation, treated with 12 gray. She was treated with the radiation within a year of her menarche, which is very important, as I'll show in a moment. She also was treated with doxorubicin, which also modifies her risk. She's still menstruating, which further modifies her risk, but she has no family history of breast cancer. And I compare her risk to a 35-year-old that was treated with twice as much radiation, but to a smaller field. Her radiation was not around the time of her menarche. She did not have any anthracyclines. She is menopausal. Her estrogen exposure is lower, and she too has no family history. Now, what you see in the first case is that this woman's 10-year risk from age 35 to 45 is 1 out of 4, almost 1 out of 4 times. That's a significantly elevated risk. In comparison, the other woman has a 4 out of 100% risk of having breast cancer diagnosed in the next 10 years. Higher than general population, but significantly different than that woman in the first example. Let me show you another example. If you want to know what the risk of women is in the general population, a super tool to use is developed by the Breast Cancer Surveillance Consortium. Here's the web link for that. You can just Google BCSC risk calculator and you can find that. This is appropriate for women in the general population who have never been diagnosed with breast cancer and don't have a specific gene mutation. So if I take a woman with average risk factors at age 40, her risk in the next 10 years of being diagnosed with breast cancer is 1.5%. Or if I took 1,000 women, I would have 10 to 15 of those women that would be diagnosed. A woman with Hodgkin lymphoma at the age of 13 treated with involved field radiation. Age at menarche was not within that 1 year time period, and she's postmenopausal at the age of 30. Her risk is 9%, 9 out of 100. Or if I take a Hodgkin lymphoma patient who was diagnosed at age 13, but her radiation was around the time of menarche, and she had a wider field, she had a mantle field, and she was treated with anthracyclines, and she's still menstruating, you see her risk has gone up to 32%, 1 in 3 chance of being diagnosed with breast cancer within the next 10 years. So this gives you a tool. I use this actually fairly frequently. I used it yesterday in clinic in walking through with one of my patients. And so you can use this to give women a sense of their risk as they try to wrestle with what they're going to do with either imaging or other measures. Now, I mentioned a moment ago by the Peter and Skip Joe Neglia study that the higher the dose, the higher the risk. But if you also gave ovarian radiation, you lowered that risk. And so the question is, what about the woman that now has ovarian failure, but I give her oral contraceptives? Do I go from a low risk to an elevated risk with that? What we found in looking at all of this information of our risk factors is that it's very minimal impact on that. So as a clinician, I can feel comfortable in prescribing oral contraceptives to my women that have either acute ovarian failure or premature menopause to relieve their symptoms. And these findings were confirmed by our Dutch colleagues around the same time. This shows you a couple of those risk factors that I've mentioned. We looked at a variety of different time periods around menarche, and what we found is that 1 year plus minus is really the driver of risk on that. And that's when the breasts are proliferating in their development. Also, the amount of estrogen exposure, and we've ended up with a cut point of 10 years or more of estrogen exposure or intact ovarian function. So this brings me to a clinical ethical conundrum. This is one of my patients that I followed for many years at Sloan Kettering. He was treated at the age of 19 for CNS histiocytosis with an allogeneic stem cell transplant. He had ovarian cryopreservation prior to her total body irradiation. He developed acute ovarian failure, which is pretty typical after a TBI. 10 years later, she was healthy. She was doing very well. She was married. She had ovarian reimplantation. If you want to watch some fascinating videos, you should see how the GYN surgeons do this. It's fascinating. So it was successful in her case. She was able to get pregnant with IVF and had a full-term pregnancy. Interestingly enough, after she delivered, she actually started having regular menstrual periods on a regular cycle. So her risk of breast cancer went from her radiation, increasing it with her TBI, to decreasing it with her loss of estrogen exposure from her total body irradiation. And now she's drifting up and she wants to have another child. That becomes a little bit of an ethical dilemma. So her and I talked about it, and obviously we opted to image it, but always recognizing that there is some risk with this, and we need to be thinking about that and inform our patients. So let me move now to a very exciting area that St. Jude and our colleagues in the Netherlands really have been leading the groundbreaking area in this, and that's what the gene radiation interaction is. First paper that noted this was led by Tim Best at the University of Chicago, and they identified a couple of variants within chromosome 6q21 that were associated with radiation-induced second cancer and Hodgkin lymphoma. And important is, all of these discoveries always need confirmation. And over time, we've not been able to confirm that original finding with further study. Around the same time, our colleagues in the Netherlands did a really nice study looking at a gene array and showing that women who had breast cancer after radiation, after their Hodgkin's, had a different gene array than women in the general population. There were differences of the drivers of that in addition to the radiation. Lindsay Morton has been a real leader in this area. Lindsay at NCI working with Smita Bhatia and our colleagues at the CCSS published a really nice study looking at women who had breast cancer following their childhood cancer. And you see their different populations here by the cancers, the radiation exposure, and their median age. And Lindsay and the group again identified a couple of chromosomes associated with elevated risk. And those SNPs, those variants, are associated with breast cell development and breast cell proliferation, and have been implicated potentially in breast cancer development in the general population. So the hypothesis is that these germline variants are pro-proliferative, pro-invasive in the phenotype that they create among the woman that supports a growth of malignant cells following transformation by the ionizing radiation. And it's evidence that germline genetics outside of high-risk syndromes such as BRCA1 or 2 or P53 mutations can modify the risk of radiation exposure among this population of women. There has been a number of other studies, one by the St. Jude, another by our colleagues in the Netherlands, that have looked at polygenic risk scores. If one or two variants is important, what if I put a panel together of multiple variants together and showing that those with multiple variants having a higher risk than those that have fewer of the variants. I talked a little bit about the genetic implications. Another exciting area is what happens when you look at radiomic features, either on the mammogram or on the breast MRI of these women. First, let's look at the general population. I mentioned a moment ago the Breast Cancer Surveillance Consortium consists of about 2.5 million women in the US. And so this is a study that Heidi Nelson and colleagues published a few years back, looking at key risk factors for women aged 40 to 49. So if we extrapolate that to our population, what you see is if women have either a BI-RADS3 or BI-RADS4, which is heterogeneously dense or extremely dense breast tissue on their mammogram, that elevates the risk of their breast cancer. We also know that there's some biomarkers on breast MRIs. In the WeCare study led by Jonine Bernstein at the Sloan Kettering that involves people both in the US and in Europe, they identified that background parenchymal enhancement. So if you look at a breast MRI report, our radiologists always report what BPE is. And what they found is when they looked in this large case control study and they adjusted for a variety of different factors, women with moderate to marked background parenchymal enhancement compared to those women that had either minimal or mild had an elevated risk of about 1.5-fold. So here's a couple of imaging biomarkers that may predict risk among these women. So Heidi and I worked with our medical physics group at Sloan Kettering, and we realized that most of these women have had lots and lots of CTs over their lifetime. The average number of CTs of our women who had Hodgkin's lymphoma was 7. So we were able to take these CTs, load them into a repository, and we created a semi-automated manner of being able to quantify their breast density by CT scan. And so we were able to look from their staging CT all the way out to subsequent years. And we could overlay their radiation portals on this and look at inside, near, or outside of the radiation field and how that impacts breast density. Not only breast density of a woman in her 30s or 40s, but also around the time of her radiation. Unfortunately, after several attempts, we were not successful in getting funding. I think when we submit to the NCI with these projects, with other limitations that we might have had in our approach, they often say, too small of a population, and you're already screening them. So we went to another way. When I moved to Duke, I started working with Maciej Mezarowski. Maciej is an R01 funded investigator that is using other radiomic features, using both artificial intelligence and machine learning to identify things on both a mammogram. I'm sorry, that was Siri chirping in. Finding factors on both a mammogram or a breast MRI to be able to predict risk of a woman that's of breast cancer. And this just shows you a couple of the figures from this type of work. And so Haya, Maciej, and I worked with colleagues at a number of centers around the US and Canada to develop an approach of having a repository. And we actually started piloting this by taking imaging studies from our Women Empower 1 and Empower 2 to show that we could actually do this. We were going to look at a variety of different factors that would impact the risk that we could look at with either a mammogram or a breast MRI. Again, unfortunately, we have been unsuccessful in getting funding from the NCI despite a couple of attempts. I think, when we put together these studies and we have 200 or 300 women with breast cancer, when you look at the general population, they're looking at 10,000 women with breast cancer and just massive imaging biorepositories. So we don't stand very well in the study section with our smaller population, despite the fact that these women have a fairly elevated risk. So you might also ask, in addition to predicting risk, what can we do to prevent it? This was a valiant effort by Smita Bhatia and her group, where they led a phase 2B study to randomize women to receiving either low-dose tamoxifen or a placebo over a 2-year time period. And the goal was, if you reduce their mammographic density, will that portend lower risk of breast cancer over time? So the primary outcome was breast density. And they were able to achieve that with this relatively small study. In fact, the tamoxifen did lower density as defined by the mammogram of women that were treated with tamoxifen versus placebo. What Smita and others that have worked in this area will tell you is it's really very difficult trying to get women to take tamoxifen as a prevention agent. That's true in the general population, and it's true in our population. A sizable number of these women withdrew from the study. I want to emphasize they were withdrawing for side effects of placebo in the study just as often as they were from tamoxifen. And we see that in many of our studies across the board. And women were having competing risks. 2 of the women had myocardial infarctions during the study, 1 from each arm. So there's multiple things when we study this population that really impacts our ability to follow them over a period of time. You might ask, what about prophylactic mastectomy? In a recent study from St. Jude lifetime cohort, I noted that there were only 7 women of their cohort that had ever had a prophylactic mastectomy. In my clinical experience, I've had 3 women that have had a prophylactic mastectomy. If instead we look at women in the general population that have a BRCA1 or 2 mutation, the likelihood of having prophylactic mastectomy is much higher. And that's because they have this familial cue. Their mother or their sister or their aunt had breast cancer at a young age and often died from it. And so the idea of having a prophylactic mastectomy is much more amenable to that population. Whereas our women have already been through a cancer, they've often had surgery, they've had radiation, chemotherapy, and they often think, I just do imaging. So I think that that's an interesting thing. I counsel women often about this, but in my experience, again, it's fairly uncommon. So what we're trying to do over time is move from these very broad outcomes that we looked at early on to a more precision-based, using radiogenomic approaches if we can, better understanding that interesting dynamic between a micro or cellular, the higher the dose, the higher the risk, versus a macro and a stromal environment where we cause inflammation in an area which we see with a larger field. We hope to see the ability to use our different blood biomarkers, cell-free DNA. Greg and I were on a call with a group not too long ago where they're looking at enriched populations to see if we can identify individuals with solid tumors, including breast cancer, prior to the diagnosis that we would see with our normal screening tests. And that would allow us, again, to stratify screening or to have prevention or even intercept that second cancer. I want to go back to where I started. This is Sarah. I saw her a number of years ago. She was asking about her health. In fact, she really didn't ask about it. I was pondering, what did all that radiation do to her? And her risks, just simplistically, her breast cancer risk at that time period, I did not know it, was 14% over the next 10 years. She certainly was at risk for thyroid disease, cardiovascular disease, other subsequent malignancies, pulmonary disease, et cetera, et cetera. And certainly what many of these women have learned to live with over time, and that's a sense of uncertainty that brings on a lot of anxiety. When's the next shoe going to drop? So questions for discussion. Have we reduced risk with contemporary radiotherapy techniques? David Hodgson's shown beautiful work showing going from the old mantle field to involved nodal, or even using proton radiation. But like it or not, we still need lots of radiation to cure these cancers. We're still probably above that threshold of risk. How do we quantify harms associated with our surveillance strategies? And often we're asking women to do multiple studies, get a breast MRI, a mammogram, an echocardiogram, et cetera, et cetera. Can absolute risk, such as what we developed in our risk prediction model, be used for counseling? Can we identify genomic and radiogenomic biomarkers for prevention? And what can be generalized both directions, from our work to other high-risk groups or from other high-risk groups to our group? And with that, I'll leave you with my email for those that are interested in questions. And for our cyclists in the audience, this is in Saint-Emilion in Bordeaux back in October. And thank you very much for your attention. And I'll turn things back over to Melissa and be glad to answer any questions that I can.
Thank you, Kevin. That was excellent. Folks, put your questions in the chat box. I have a few already. I am personally intrigued by your roughly 50%, just over 50% response from the family physicians or primary care providers of women in the Empower study. What have you learned? Can you share what sorts of information did you request of them, and how did they respond?
Well, Melissa, as you will remember, we've learned a lot over the years. We conducted a study years and years ago looking at programs for adult survivors of pediatric cancer, and reached out to pediatric oncologists at that time, and we had a 92% participation rate. Incredible. It was an interesting topic and a population of providers that were motivated to answer the question. When Tara Henderson started approaching our generalists, primary care providers, family physicians, through work in her K Award, we used a very simplified survey, a very short thing that you can answer in a couple of minutes with that. What we saw is that when we looked at our primary care providers, hitting 50% is pretty much a pretty good mark and publishable. And in fact, if you look at PCPs answering surveys, they're busy. It may or may not be interesting to them, and often response rates are around 30 to 35%. So it's really important to have a short thing that is of interest to them. We personalize it to your patient. Your patient, so-and-so, is participating in this study. We've sent you information. We're interested to understand your beliefs, knowledge of this population. And we kept the surveys short. Our research coordinators call multiple times, pestering our PCP clinics. So we've been happy to get up to 53%. I'd love it to be higher, but I'm happy to be at least at that 50%. So the moral to the story is, if you're actually surveying providers out in private practice, keep it short, germane, and if you can personalize it.
Okay, that's good to know. And another question relates to anthracycline exposure and how you're currently using that in your breast surveillance recommendations. Is that data is evolving? Your thoughts?
Melissa, you should chuckle because we've had lots of conversations over this. We know over the last several years that anthracyclines increase the risk of breast cancer, both among women who were irradiated to the chest area, but also women who were not. There's a very nice study that was done by the St. Jude group, led by Matt Earhart, that showed that it wasn't really being driven by P53, though many of us still suspect that there's probably some gene interaction there on that. It's incorporated into our breast cancer risk prediction model. So if you go online and you use that in counseling, that actually elevates women's risk if they had anthracycline exposure. That being said, we still haven't incorporated it into our guidelines, although we've had much discussion about that.
Okay, there's still more questions. Would you comment on the risk of boys with Hodgkin's disease related to breast cancer?
I love that question. And I should even think about it. In my clinical experience, I've had two men with breast cancer following Hodgkin's lymphoma. I always do a breast exam on every male that I see that's had chest radiation. So, and I actually talk with them about breast awareness. If you feel a lump or a bump or notice a change, let me know. And I'm talking with them about other things too. In the CCSS, we've only had one or two men with breast cancer out of a fairly sizable number of men that were irradiated. So there certainly is risk. It's probably not much higher, if at all, than the general population. Statistically, it's hard to be able to compare with that. So the two morals of the story that I'd say is be aware of it and counsel your men about breast awareness.
Okay, another question. Excellent presentation as always. Perhaps an impertinent question, but where do your percentages figures come into play if any radiotherapy should trigger surveillance anyway? So put on your guideline hat and your survivorship hat and give us some practical advice.
Well, one thing that I'd say is I sure prefer being in person rather than a Zoom. I sometimes feel like I just don't have the sense of how the audience is through a talk. So thank you for your positive comment. Where are we on percentages? Well, for the COG, we decided that there wasn't a dose threshold. And the reason is that we've shown that 10 gray or higher is elevated risk, but we rarely use therapeutically below that. Somebody might have had an emergent mediastinal dose, but that's pretty uncommon with that. I also will say at this point that radiation oncologists are both my best friends in practice and in taking care of our patients. And sometimes our radiation oncologists start saying, whoa, what did we start? I remind them that they saved a lot of patients that made their way to us. And we remind our patients that radiation was important to achieve that cure. And that our radiation oncologists and our medical oncologists and pediatric oncologists have really led the way trying to reduce the size of the field, the doses and that. But at the end of the day, we still have to achieve a cure to get to the point where we can even talk about surveillance. So I don't think that there's a dose threshold for breast cancer screening in this population because basically everybody that gets therapeutic radiation is above the established threshold.
All right, what about the role of radiation received by organs playing a role in the immune system? Has there been any relationship of this in cancer risk, breast cancer risk, or other cancer?
Such a great question. If you think about it, we and others have tried to understand the role of even the spleen. Back in the days of staging laparotomies and the spleen being removed, does that impact it? And there's been some things that suggest that it might or might not, but the numbers have been relatively small, but it's hard to tell that. We never saw that pan out either with patients that had a high dose of radiation to the spleen that was left intact in the body with that. So if you think of one of our primary immune organs, that has not come to play, but I think statistically it's been difficult to answer it one way or the other. I'm not aware of really good studies that have looked at it beyond that. Our old approach for using radiation was total nodal. I mean, we hammered the immune system with radiation on that. But we also had high doses, often with cobalt radiation. And so the fact that we saw a lot of breast cancer in that population is not surprising.
Okay. Here's an interesting question. I know that you guys have done some research in looking at what is motivating participation in breast cancer surveillance. What percentage of cases do not get screening mammograms following radiation are simply resistant to getting mammograms regardless of availability and regardless of physician recommendations? That is denial. They don't want to test because they don't want to know. I mean, of course, you have the population that's more engaged with you, but what have you learned about that unengaged population or resistant population? Any thoughts?
Yeah, I do. I think of the world, try to find my camera, as the bell-shaped curve distribution. And that's true of decision-making of patients. That's true of decision-making of providers. And we always have people on either end of that. I've had times when I've done imaging studies that we decided afterwards were not warranted for patients, but patients say, That's all right. You told me I didn't have anything. I was glad to get it. I'll get imaging anytime. And we know there's patients on the other end of that spectrum that are just wired differently and they don't want anything regardless. So there's always a population there. That being said, I have found that most women are actually really interested in this. And I think that our providers tend to be the more common barrier or the competing demands. There are other health issues or having families that they have to take care of, kids that they've got to get to X, Y, and Z. One of the comments that I'll mention anecdotally, Melissa and I led a study eons ago, funded by the Livestrong Foundation, where we sent out treatment summaries to men and women who had been treated for Hodgkin's with radiation. And for the women, we were telling them they were at risk for breast cancer, go get a mammogram. And it was a pilot study that led to our Empower One study. And the women that we interviewed 6 months after that said pretty much the same thing. This was liberating. This is the information I needed. I really liked it. We did not cause anxiety in that. We were actually informing of things that they thought were important for their health. The men who were telling them to go get an echocardiogram were a notch below that, saying, this is helpful, however. I appreciate this, but, and so it's really interesting looking at this very difference between men and women. That study also led to ECHOS, the study led by Melissa, that showed that we can increase the rate of men and women getting their echocardiogram after their cardiovascular exposures.
Okay, I have a great comment, and this is actually a good discussion point from our close colleague, Sandy Constein, noting that there's incidental radiation exposure from fields that are not strictly mediastinal and axillary. And I will share that in evaluating our survivors in the St. Jude Lifetime cohort who've not been with us for many, many years and had, treatments, with cobalt, and you would think, oh, that's a field the breast should not be affected or exposed. And we could tell even on physical exam, it surely was. And so it really emphasized to us the need to understand the target organs at dose and how important that information is shared. What's your experience with that?
Our MD Anderson group that's really done great work in trying to look at the dose of radiation to areas both inside and outside of the field has led the way from that. And certainly Sandy has been involved in a lot of that effort. So I think that we need to stay tuned. I do think that those exposures are important. We tried to address that to a degree when we looked at the breast cancer risk calculator and some of the work that led to that of women that had a high abdominal field, knowing that sometimes these fields go all the way up to the nipple line in these young kids with that. And again, we see a little bit of a risk, but the numbers are so small to tell on there. So I don't know the answer, Sandy. I do think that these exposures are important. And what I do say again is I congratulate all of our radiation oncologists, including you, for leading the way in thinking through that and trying to reduce these exposures while still maintaining a cure.
Yes, right. Okay, we're at the top of the hour, so let me officially close the event. But remember, Dr. Eppinger has agreed to stay on, and I'd like to thank him for his excellent talk. So we'll close the formal event, and those who are interested in staying on can stay for continued discussion. We still have a few more questions in the chat box. Before we get back to questions, thanks to everyone for coming. I encourage you to visit the website and mark your calendars for other upcoming talks, including the next survivorship lecture that will be given by our own Dr. Yutaka Yasui on what can we learn from GWAS data, genetic heterogeneity, and rare variant hypotheses of cancer risk. That will be on April 14th. And then please note our next lecture next week is February 17th. Dr. Akiko Shimamura from Dana-Farber, Boston Children's, and Harvard, who will be presenting on clonal evolution and somatic reversion and genetic predisposition to TP53 mutated myelodysplasia. So great lecture. Thanks, everyone. And those who want to stay on, a few more questions. We'll keep going. All right. So, Kevin, excellent presentation. We're going to make you get your money's worth here.
Can I jump in, Melissa?
Sure.
I see a really nice question that I should learn to make clear in my talks from Trish Murphy asking about working with OBGYNs. I consider OBGYNs to be primary care providers. Many of the national organizations do as such, and we have two OBGYN providers on our PCP advisory board for Empower 2, and we send it out to the patients, OBGYNs. Interestingly enough, we haven't seen an uptake any different one from the other on that. So I just wanted to jump in with that real quick clarification.
Okay, thank you. All right, any data on the impact of dexrazoxane on risk of breast cancer in patients receiving anthracyclines alone?
Nita, great to hear from you. I hope you're doing well. Look forward to when we have in-person meetings once again. We didn't have enough people with dexrazoxane to be able to determine if it has a risk on there. I think that that's still a stay tuned, but I don't know that we'll ever have enough. I think that the real question too will be what Eric Chow and Steve Lipschultz show from their study on dexrazoxane in preventing long-term heart failure, and I'm very interested in that work.
Okay, you see one from Goli here. Can you please comment on role for duration of estrogen replacement in women with ovarian failure at risk for breast cancer? When should we stop hormonal replacement therapy in these women in adulthood?
Goli, I look forward to the time when you're doing these science talks. Congratulations on your recent funding successes and your great work. We tried looking at a variety of different categorical variables. This is an area that Flora Van Leeuwen, Cecile Ronkers, Haya, and I are very interested in. Malcolm Pike is a epidemiologist at Sloan Kettering that is extremely well known in this area of estrogen exposure and the risk of breast cancer with that, and Malcolm worked with us. And it was hard to quantify it. As you can imagine, asking a woman what she did with her oral contraceptive practices 25 years ago, much less 5 or 10 years ago, was difficult. And we had a lot of time piecing together those variables through the questionnaires on there. So I think it's crude. What I can say is we simply didn't see that OCP with, especially in women that were on an estrogen plus a progesterone, was impacting risk. And I felt much better once I saw that our Dutch colleagues confirmed the same finding. Again, we need to always remember in our research to confirm each other's work to make sure that what we have that might look pretty impressive at first, such as the Tim Best publication, may not bear out over time.
Okay, I think this is interesting. Great talk. Has anyone looked at the role of involving a partner spouse in these recommendations and any thought of how it might improve compliance? Have you been able to explore that in the oncoprimary care setting?
Yeah, Diane, great question. I wish we had thought about that with Empower 2. Whether or not reaching out to the males on that. I learned a valuable lesson working with Leah Zulig, a population scientist that co-leads one of my R01s, where we're working with patients with newly diagnosed solid tumors in adulthood, not pediatric cancer survivors. And we're very interested in adherence to their cardiovascular medications. And I always would have said women are more adherent or compliant to their medications than men. But as we looked at the literature in preparation for that study, we found that women actually had a lower adherence rate to their medications than men. And I thought, well, that just doesn't make sense to me. And Leah reminded me that often the woman is the kind of the caretaker of the family, and they're doing so many other things that is at risk to their own health, and they're more likely to be non-adherent to not only their medications but other screening. So your question, Diane, is could we have impacted it by reaching out to their partner, their spouse, etc., is an interesting one. Unfortunately, we didn't do that. Melissa, back to your question on whether we're doing that for oncoprimary care. We're actually looking at a whole host of different screenings. So one of the areas that we're interested in prostate cancer screening, and yes, we do reach out to the spouse or partner of those men, and we find it to be very, very helpful with that. So important point and something I'd love to include in my future studies.
Yeah, it's an interesting point too in a pediatric center. Even as we see survivors, adult survivors come back, it's not uncommon for them to come back with parents and parents to be driving, a lot of their activity, or they need to, they're relating concerns. And sometimes it's their new partners that do that, but we've never engaged beyond the survivor. It's all been very directed to the survivor. So I don't know if it's different with an adult onset cancer, but it's definitely a family affair with all of these issues of importance. I
You're
have
right.
one
I should
practical.
reach out to their mom.
Yes, exactly, exactly. Um, one question, one comment made by our Tim Foltz, our family physician in ACT and St. Jude Life, and it is critical that he's emphasizing the need for primary care providers to, have information about radiotherapy planning images or target organs at risk to improve their understanding. I've been convinced that probably what we are giving is too much, and the simpler the better. And maybe with these newer technologies and radiation, you can readily assess the target organs at risk. We need to find a way to get that information at a very basic level. Those first 7 seconds, as you said, are critical, and so we're not wasting time with a lot of other detail that may not get the point across as well. I have a practical question. What do you advise young women who want to alternate their mammography and MRI? How do you feel about that? The guidelines say dual. Some people are alternating, some are doing it concurrently. I'm just curious what your thoughts are.
We will never have data to answer that question either in our population or in BRCA or other familial genetic mutation carriers. There just isn't enough to be able to look at interval cancers if you're doing a Q6-month mammogram followed by MRI or doing a combination. I always tell my women that if I have a preference, I'd rather alternate because it gives me a little bit of a better chance of capturing that interval cancer. But you have to be a little OCD because things are easy to get out of kilter, especially we saw with COVID. People's screening practice really got messed up. So I said, if you're OCD like me, let's get them alternating. If it's easier for you to get them at one time, that's still our standard and it's still a great way to go. Can I answer another question I saw on here from Blanca Diaz? I think it was from Blanca that I saw earlier.
Oh, I'm sorry, I missed it. Yeah, please do.
Radial spinal radiation, and that's so important. I tried to address that with a publication a few years back where we looked at all of the patients that had cranial spinal radiation, either from a medulloblastoma or old ALL regimens. And we found in the cranial spinal population, we had 0 women who had breast cancer subsequently. And in the ALL population, we had a couple, but it was no different than what we would have expected in the general population. And also recognizing that some of these women with ALL may be carrying a P53 mutation. So really, really important. My radiation oncologist and radiation physicist remind me that with radiospinal field, you're getting about 10% of that dose coming in through their breast. So over time, we may see it, but to date, we have not seen that's triggered an excess risk.
Okay. All right, I'm scanning. I think we got them all. It was a great discussion. So I will thank everyone. You still have people hanging on to get any information you can pass, but thank you for your participation, everyone who stayed with us for this extended discussion. And Kevin, thanks so much. It was really great to hear the talk and have the discussion and see you and how well you're doing. And we look forward to hearing more about your efforts in oncoprimary care and how that is going to be advancing care across the survivorship spectrum. We expect to learn a lot more about you as this research extends.
And I look forward to seeing everybody in in-person meetings. Stay safe, stay healthy.
Okay. All right. Take
Thanks,
care.
Melissa.
Bye, everybody.